Good morning and welcome to the Virginia Hospital and Healthcare Association's Home is the Hub readmission webinar. Home is the Hub is an initiative to accelerate progress to reduce readmissions in Virginia hospitals. The title of this morning's presentation is a Readmission Reduction Playbook that we will review, and hopefully everyone has had access to. It was released last month. A few housekeeping notes before we begin the presentation. The slides for this morning's presentation were sent to all of the registered participants last evening. This webinar is being recorded. If you did not receive the handouts last evening, if you look in the handout section of the webinar control panel, you will be able to access the handouts from that section. All the participants will be muted throughout the duration of the webinar. If you would like to ask a question at the end, there is a raise your hand icon in the control panel that you will be able to click, and we will be able to unmute your line. You will also have the option of typing in questions in the chat box, and the presenters will be able to respond to the questions at the end. And our plan is to have all questions responded to at the end of the webinar. So the objectives for this morning's webinar are as follows. We want to reinforce the need to continue efforts to reduce readmissions in Virginia hospitals. So hopefully everyone will leave with the understanding of why that continues to be an important priority for all Virginia hospitals. Secondly, we hope the participants will understand how to utilize the high leverage strategies that are discussed in the Home is the Hub Readmission Reduction Playbook, so that you'll be able to build on the portfolio of strategies that your hospital is already using to reduce readmissions. And then finally, we want everyone to be able to leave in action, and so hopefully everyone will be able to identify at least one action they can take and follow up to this morning's presentation. In order to accomplish those objectives, we will follow the agenda as listed on your screen. I will do a brief review of the VHHA statewide strategic improvement priorities, and then I will turn it over to my colleague, Mr. Peter Mulkey, one of the CEOs from a Virginia hospital, who will do a brief case study on their successful efforts around reducing readmissions. Then Dr. Amy Boutwell will review for us the contents of the readmissions reduction playbook and how each of the participants can put it into use at their facilities. Then our colleague Carla Thomas from Health Quality Innovators will provide some insights from the work that they're doing regarding care transitions around Virginia. We will have an opportunity for you to ask questions of the panelists, and then we will have closing comments. So if many of you have been involved in our webinars over the past year and a half, you will recall that in 2014, the VHHA Board of Directors identified a set of strategic improvement priorities for the period 2015 to 2020. Those priorities included reducing hospital readmissions, reducing healthcare-acquired infections, specifically C. difficile, improving the patient's experience of care, and being able to identify, learn from, and reduce serious safety events in Virginia hospitals. Of course, today's webinar is focused on that first strategic priority, hospital readmissions, and the specific target that was set by the VHHA Board of Directors is to reduce hospital-wide post-acute transfers and total hip, total knee replacement readmissions by 20% by 2020. So in the next few slides, I will provide a brief overview of data that shows our progress to date. So this slide shows the progress regarding hospital-wide readmissions. We started with a statewide baseline of 9.13% readmissions for hospital-wide readmissions. Now this is for all cause, all payer, non-adjusted readmissions. As you can see, we have been able to, for the most part, remain below our baseline, although in late 2016, we sort of got back to the baseline, and that green line represents our target. So the good news is that readmissions are not going up drastically in Virginia, but clearly we've got much work to do if we want to reach our target by 2020. So opportunities available to us across the state. Our next category is post-acute transfer readmission rates. We started with a statewide rate of 11.67. Our target is to get down to 10.49 by 2020. Slight improvement there, but not quite where we would like to be. We jumped ahead a little bit, so there we go. So with our post-acute transfer readmissions, we've been able to stay below our baseline, but have some work to do to get to our target by 2020. And then finally, total hip, total knee related readmissions started with a baseline of 3.45%. Target was get down to 3.10%. Our performance on a quarterly basis has been quite erratic. So the message here is that we've got to find a way to be a little bit more consistent. And the good news is that we were able to reach our target at the end of 2016. We saw some increase in that rate at the early 2017, and clearly more work there to do to be more consistent with that rate. So we are glad to know that there are some folks in Virginia Hospital that are seeing success. One of them is Clinch Valley Medical Center. And so at this time, I'm going to turn the presentation over to Mr. Peter Mulkey, who is the CEO of Clinch Valley Medical Center, that will review with us a brief case study of some of the work that his organization has done to address readmissions.
Thank you, Abraham. Clinch Valley Medical Center is located in Southwest Virginia. We're a 175-bed facility serving the about a 5-county area here in Southwest Virginia. One unique thing is over the last probably 6 to 7 years, we've seen our unemployment rate climb to somewhere between around 7 and 9% is typically what we're running. We're kind of an energy-driven area out here, a lot of coal mining, a lot of natural gas, and certainly that's been impacted over the last few years with some loss of jobs. Next slide, please. What I'm going to talk to you about today is a program that we entered into about 4 years ago with a community partner here in the Richlands area, Appalachian Agency for Senior Citizens. They were actually initially doing a transition program that they were receiving some federal dollars from, and they were able to concentrate on a certain population of patients, and that's when we initially partnered with them. And during that initial first year, in all honesty, we did not see our results change a whole lot because they were somewhat hamstringed by the federal grant that they were getting, and it did not allow them to branch out into some patient populations that we wanted to be involved in. And I say this after the fact. They lost that grant money. It came to an end and was not renewed. And actually, that was the opening of the door for our program to really get on track. And I'll talk a little more about the program as we jump through these slides here, but I'm going to just give you a brief case study of one particular patient, and we've seen many of these patients since our program's been up and running over the last 4 years that we've been able to make significant impact. As you can see by the slide there, we have a 64-year-old female with really a laundry list of health-related issues that they are having to deal with. In 2016, the second half of 16, This individual was admitted 11 times for inpatient stays during that 6-month period of time. So certainly they were on our radar screen. We knew that they needed some help beyond what we were able to provide just during those hospitalizations, that we needed to have some eyes and ears in that home to help that patient get on track. And oftentimes when we put these patients into what we call our bridge program, we find out that there's a lot of things going on in the home that may be a little different than what we were told while the patient was in the hospital. Oftentimes patients are very proud, don't want to tell you some of the struggles they may have in the home. But anyway, this individual with all these particular issues going on with their health really had a very low understanding of their many health issues and how it impacted their really day-to-day living. We saw a patient that was on 16 different medications. Several of those they were unable to afford and really were taking them not at all or very sparingly. We found that they were on 5 liters of oxygen by nasal cannula, which is certainly a very high rate of oxygen. They had been on BiPAP for over a year, but had never actually used the machine. And they just needed basically assistance in pretty much all activities, and they were very deconditioned that we found this patient. Next slide, Abraham. Next, oh, okay. So we entered the person into the bridge program, and that's just a name that we came up for our program with Appalachian Agency. And like I said earlier, they're really the eyes and ears of the team in the home. They typically are in the home within the first 24 to 48 hours after discharge. And this is a little different than home health, what home health can do. These people really dig in, even what I would say, even a little deeper than home health, and really get to know the patient and develop that trust between the patient and the person from Appalachian Agency to really help this patient improve their quality of life. We found out, like I said, she was not using BiPAP, and we found out that she did not use the BiPAP because she was just not able to get the mask on correctly, and really had no way of doing that. She did not have a mirror in the home, did not have a mirror in the bedroom. So one of the first things that was done, there was a mirror that was mounted to her bed, facing down, so she could actually see how the mask was supposed to go on, and making sure that she was getting it on correctly. Also, with one of our other community partners in DME, we changed her equipment to where it could be monitored electronically, so the therapist knew each evening if the patient was actually using the equipment. And if they weren't using the equipment, they would make a call to that patient around 9 or 10 o'clock at night to make sure that they weren't having any problems or anything out of the ordinary was going on. So first and foremost, we were able to get that person compliant on their BiPAP. She was basically, initially, she was unable to really cook for herself and really to have adequate nutrition for herself. Appalachian Agency does many things, and one of the things they also do is they provide Meals on Wheels, so to speak. So that patient very quickly got signed up on that plan and began to receive meals that were beneficial to the type of disease state she had. So that was certainly a positive. I mentioned she was deconditioned. We sent physical therapy there to really work with her and get her on a program that she could do to improve her stamina and her overall health in terms of wellness. Pharmacy got involved on day one, and we quickly found out, even though she had never admitted that to us while she was an inpatient, she had 16 medications, of which several she could not afford because the Part D plan she had really did not meet her needs. So we worked with her local pharmacy, our hospital pharmacist, and her physician got her transitioned to a different Part D plan, and also were able to talk with the physician to get her some therapeutic substitutions with some of her medications that really was able to drive the cost of those medications down. So very quickly after she entered into the bridge program, we were able to get her all the medications that she needed. She was having to travel quite a distance. It's not unusual out in this part of the country that people will travel 30, 45 minutes, maybe even up to an hour to see a primary care physician. That was one of her problems. Her primary care physician was located over an hour from where she lived, so transportation was an issue for her. We were able to work with her and some more local providers to establish a new relationship for her that allowed her to be able to get to her appointments. And actually Appalachian Agency was able to provide a service to her that could transport her back and forth to her doctor's appointments when needed. Again, DME got involved with her BiPAP machine, and like I said, we were able to change that to a more appropriate machine for her, plus a machine that could be monitored, and the technician could determine if she was actually using the machine. Home assessments obviously is a part of this assessment that Appalachian Agency does, and really try to identify other types of problems in the homes or issues they may be having. Do they have adequate heat? Do they have running water in the home? Do they have all the things that many of us just take for granted every day that certainly is a barrier for them getting the appropriate care that they need? Next slide, please. So kind of what was the outcome with this patient after entering them into our bridge program? Well, since being in the program in 2017, this individual had no admissions to the hospital. She lost 70 pounds, which I think we could all see was probably contributing significantly to some of her diseases. She uses her BiPAP now every night. The therapist has not had to call her in over a year about the use of the BiPAP. She's on a meal plan that's unique to her medical conditions. She has a home exercise program that she continues to work with on a daily basis and has made great strides in progressing in that area. Her medication usage, we were able to get rid of some of those 16 medications and reduce her down to a smaller number of medications, which she now is able to, like I say, obtain all those medications and be compliant with those. O2 got moved from 5 liters nasal cannula down to 2 liters. Like I've already mentioned, she was very compliant with her BiPAP, and that's not been an issue. And by just some tweaking with her Medicare Part D plan, as well as some substitutions that the pharmacist and the physician worked out, we were actually able to reduce her copay out of pocket by 83% in this patient. And this is not uncommon that we've seen in medications. Medications, it seems to be the biggest barrier for a lot of these individuals. And we've had many patients through the program that we've been able to make very similar reductions in what they're paying out of pocket. And today she will tell you, very proudly tell you, that she's independent. She does not have anyone that lives with her. She does have family members in the area who do check on her, but she has become very independent. She is no longer officially in our bridge program because we've got her stable and on the right track. But interesting enough, the person from Appalachian Agency that worked with this individual still does some phone call follow-ups, and on a rare occasion we'll pop in and just make sure that everything continues to go well for the patient. But again, from 11 admissions in 6 months to 0 admissions in the entire 2017 calendar year is a pretty phenomenal for this patient. But we've seen several patients like this in the program. She refers to herself kind of funnily as the little engine that could, and she's made some great strides. Next slide, please. You can kind of see from the time we've entered into the program with Appalachian, kind of where we started and kind of where we are today. And as you can see there, we've gone all the way from just about 12% in 2004 down to just slightly under 8% as we finished 2017. And early results in 2018, we're only into almost 2 months now, but our January readmission numbers that we look at very closely, we have actually dropped down a little lower, down to about 7.4% now. So we hope to be able to maintain that. We have a internal goal of trying to get down to 6.9%. So we hope to be able to get to that point in 2018. So that completes my conversation about this particular case study, and I'll be more than happy to answer questions, I guess, as we do that at the end of the presentation. Thank you.
That's fantastic. This is Amy Boutwell, and I just really appreciate you joining us and sharing the story of success for that individual, as well as for everybody who's been served by the program. And your hospital-wide readmission reduction is something that I think we all aspire to see a run chart like that. And so many great lessons from learning from what that one person needed is exceptionally emblematic of the multiple things that we need to be thinking about, working on, and iterating and problem solving over time. And really, it is that work and that great example of your team and the collaborative partnership you have with the Elder Service Agency that will get us all readmission reduction. So what a great way to start off the webinar. Thank you so much. So I have the distinct pleasure of sharing with you today the Readmission Reduction Playbook. The Readmission Reduction Playbook is a compilation of the 1.5 years worth of content that we have shared with you in the Home is the Hub initiative. And as we reviewed and looked over the numerous webinars, the in-person learning sessions, the resources that we have shared and mobilized over the past 1.5 years, we got to thinking that we needed a way to distill down the rich content, hours and hours of content that has been created, and we wanted to boil it down for you to remind you of, I guess, the strategies we've discussed, the key points, and distill all the information down to this playbook that is really meant to be kind of a prompt and a reminder and a workbook of sorts as you move into your next 2 years of readmission work over 2018 and 2020, as we all try to achieve the VHHA board goal of reducing readmissions by 20% by 2020. So with that as a brief introduction, I'm going to take a little bit of time just to orient you to the playbook. This part of the webinar really is hopefully going to very much serve as your page-by-page review of the playbook. And I really encourage you to make a note of what in this playbook might be helpful, what might you want to share, look at more closely, what might you want to share with your colleagues on your readmission reduction task force, or with your community partners. And as Abraham encouraged us at the beginning of the webinar, we hope that you'll take one idea from this webinar, whether it's from Peter, myself, or Carla, and move it into action as a result of working together today. So you can see here at the bottom of the slide that the Readmission Reduction Playbook, it's live, it's posted on the VHHA Home is the Hub website. The link is right here on the slide, and we encourage you to reference it electronically. And the great news is it's only less than 20 pages, and so Abraham and I are hoping that you might print out at least one copy and actually just kind of, if you will, take a page out of the playbook and work on it, and then take another page out of the playbook and work on it again as you move your work forward. So, just to orient you, I'm going to go page by page, really. So we are going to review the playbook together, and you can make a note of what's helpful and what you would like to return to or look into more. As a reminder, the leadership of the VHHA and the Center for Healthcare Excellence at the VHHA are reminding us, as Abraham said, to keep going. We are on our way toward that goal to reduce readmissions by 20% by 2020. And the run chart that Abraham showed for the post-acute readmissions, gosh, that is really going in the right direction. And if we continue to accelerate and focus on that priority area, I'm quite sure that that we can get there by 2020. So there's a lot of reason to be encouraged and a lot of reason to take what we have already learned and shared together and now move into execution and implementation. And so that's a key message here from our VHHA leadership. This entire initiative was a collective effort of several partners, and you can see, we're just fortunate to bring together kind of three of the key authors on the authorship page, but want to recognize, all of the hospitals, the readmission teams, the executive leaders like Peter and others who have really contributed to the learning over the Home is the Hub initiative so far. Okay, so here's the table of contents. Again, one thing I want you to get from this is it's short. It's meant to be short. It's meant to be skimmable. We've oriented the information into 4 simple sections. Basically, the call to action, a 3-part reminder of those high leverage strategies. We're focusing on reducing hospital-wide readmissions, post-acute care readmissions, and those hip and knee readmissions that we need to get a little bit more reliable and consistent on, as Abraham said. The whole thing is just 18 pages, 1 page per topic. So we really, those of you who have attended the webinar series and the learning sessions, that we've had 90-minute webinar presentations with 50, 60 slides per session. And what we've really tried to do is make a specific effort to just boil it down to those key concepts, those key points, key recommendations, so that you can really work with this 1 page per concept structure that we've put together in the playbook. And again, bring it to your meeting, discuss it, review it, and we're hoping this will be very functional and practical for your teams. We're hoping again that you'll use this as part of your working sessions. So one idea that you might have is over the next several readmission team meetings, you might go through just 1 page as a part of your team meeting, just to check in with you and your team. To what extent would these concepts be helpful? To what extent should we test out any of these recommended action steps? And then, of course, we can't reflect all of the content in this very brief, skimmable format. So you have the full set of resources and links back to the webinars and other toolkits and materials that we've mobilized for you in the resource section of the guide. So let's just get started. This is the look and the feel of each of the page. 1 page, the call to action and a reminder as to why we are focusing in on these 3 areas of the high leverage strategies, what the data is behind it, what the strategy is behind it, so that you and your readmission teams can align your thinking and your priorities, or at least situate your priorities in the context of this statewide initiative. The key messages here are, whatever you do, be data informed. We have talked about various ways of identifying high risk of readmission patients. We have talked about being strategic, understanding who are you targeting and why. And if you target in that specific way and have success with that patient population, will you get the results you expect to see, much like the case example that we just heard. And then a reminder that, really what keeps me going in this field is that as we work to reduce readmissions, we are really working to build the high value healthcare system of tomorrow. And so everything that we do in a multifaceted portfolio of strategies is readying all of us and our cross-continuum partners to deliver value in the future payment models of tomorrow. Here's the one-pager on the high leverage strategy of reducing hospital-wide readmissions. Just as some brief reminders, we invite you on a regular basis, at least once a year, to reflect and consider and articulate what is your current strategy to reduce hospital-wide readmissions. What does your own data suggest? If you're focusing on certain target populations, do those populations have a high rate of readmission? How many discharges and how many readmissions are in your target population? And do the math. If you have success in that target population, will it contribute to reducing hospital-wide readmissions? And that's a real breakthrough concept that we've tried to emphasize over the years. We all needed to start with a small pilot population. That is completely understandable. It is absolutely consistent with good quality improvement. So just for example, many of us started with Medicare patients with heart failure. It happens to be that that's an important target population that is at high risk of readmission, but it's not mathematically a big enough target population to help reduce hospital-wide readmissions. So that's what we mean by do the math and know your numbers. In the pursuit of reducing hospital-wide readmissions, we've discussed over the years improving standard care for all. And this is what we've discussed at various points, basically raising the quality of transitional care, risk identification, and risk mitigation across the board, not limited to your specific target population, but for me and you and your neighbor and the patient in 32B, every single person who's in your hospital probably would do well to have an updated and modernized set of better practices in a standard fashion. And then we've discussed identifying and addressing risks, again, for all patients. I might not be in a high risk category, but if you meet me and assess me to have just lost my job and have economic challenges affording my medications, well then by all means I am now high risk, even though maybe my age or my diagnosis wouldn't have otherwise put me in a high risk category. So one very powerful element that we have learned together over the years of doing readmission work is we want to target high-risk groups, but we don't want to forget to identify and address the high-risk features of any of our individual patients as they experience challenges and changes in their lives. One of the most powerful tools to reduce hospital-wide readmissions is to talk to our readmitted patients. Much like the patient that Peter shared, we need to put a human face, a human element, understand that people are not always forthcoming about their challenges, and perhaps they don't even recognize elements of their life that are challenges to their health and well-being. And so we need to adopt that practice of sitting down at the bedside, talking to patients, their caregivers, their involved providers, whoever can provide some insight and really understand the human elements of why patients are readmitted. So moving to the second high leverage strategy, post-acute care readmissions. This has been a really vibrant area of learning and improvement, and I know it continues to accelerate across Virginia, and this is a very high leverage strategy. So we start off by reminding ourselves of some key facts, which are counterintuitive, but I think we now all very well appreciate, which is in the hospital, we work really hard to screen people and identify people who qualify for post-acute care. And the way we used to do it is we used to offer the patient post-acute care, and once the patient and family said yes, we kind of breathed a sigh of relief and said, okay, great, that's a safe discharge plan. Well, what we've learned in the Home is the Hub initiative is that every patient who's going to post-acute care is in a high-risk group. The readmission rate for all patients going into post-acute care is higher than average, which now makes sense because we say, aha, of course it is. These are the patients who by definition have ongoing skilled care needs. And so what we do now is we say, if a patient is going to post-acute care, we need to now do some more things: warm handoffs, circle back, collaborative improvement efforts in terms of information flow and patient care coordination rounds or phone calls or conferences or whatever the case may be. So the statistics remind us this is a high-risk group, and the best practices are to think about our shared patients and the fact that we are now hospital and post-acute care provider. We are co-producing this outcome called a safe transition and a lower readmission rate. And that requires us to work together. And Carla is going to tell us a lot more about the circle back work that is flourishing, and more resources around purposeful collaboration between hospital and post-acute providers. A lesson that we've discussed is not only is this high leverage, not only do we have the best practices, but we need to remember that as in any human relationship, it takes time to develop a trusting, effective, collaborative relationship. And if your hospital is just embarking on this, to remember to give it a few months of regular meetings and trusting, helpful discussions in order to really be able to dig in and effectively collaborate. The third high leverage strategy area is hip and knee readmission. This is a strategy area because, quite honestly, it's driving 50%, I think, of the total penalties in Virginia. And that's, of course, a really great reason for us to say, what can we do to be more consistent and mitigate the exposure to readmission penalties for this particular group of patients. So we've been fortunate in the Home is the Hub initiative to learn from some Virginia providers that are having good success, the key concepts around providing more anticipatory guidance, and not just telling the patient to call 911 if they develop a fever or pain or questions, but to call someone from the practice or from the bundled payment team or from the care transitions team, or call their navigator. Give patients and their families someone to call, a specific name or number, so that when they do have questions, they're not left to think, I have to come back to the hospital. And that is a really great breakthrough strategy for this group of patients in particular. A dedicated navigator, a dedicated team, a resource for patients and families to follow up with. There are always little things that come up, little and sometimes big, things that come up after a surgery and during PT and recovery and everything that goes along with a hip or knee replacement. So we need to design the system that says, yes, there will be questions that come up. And so how do we anticipate that and help keep our patients from needing to return to the emergency room and get them the help they need in the home and ambulatory setting. So lots of reasons to be very hopeful that we can make a lot of good progress in this area as well. So those are high leverage strategies. We're going to now briefly move into a few special topics as we think about some specific practices and some specific ways of organizing readmission reduction work, we have a short list here of some special topics. The first topic here is about the multi-visit patient, and that is the patient that Peter described to us, 11 hospitalizations in 6 months. And as he so eloquently described, you know, it really meant that she needed something a lot more than a hospitalization. I mean, 11 hospitalizations were not enough to meet her needs. And so taking the very fact that an individual has been here so much and using that fact of high utilization as our signal that we are missing something. We are missing meeting this person's needs. That is a very helpful concept as we think about the multi-visit patient. We want to not just say, as was the case in this woman's situation as well, oh, well, she's so complicated. She's so medically complicated. Well, yes, people have medical complications, but not every person on BiPAP who's overweight and socially isolated is a high utilizer. So what is making this woman struggle? And we heard all of the numerous things that needed to be addressed in order to stabilize her needs. So some key concepts here are look at multi-visit or high utilization as a symptom. It's a symptom that we are not yet meeting the patient's needs. We want to identify what is driving that utilization, so as we call it, the driver of utilization, and we want to address those drivers of utilization. In many ways, yes, there are medical needs involved, but as we heard, a lot of the solutions are logistical in nature. They are very human, and they don't necessarily, require more medical thinking, medical diagnosis, medical treatment. As in this wonderful case that we heard about, she required humans to help her, to put the mirror on the bed, to order a different type of BiPAP machine, to simplify medications, to move her to a different and more affordable medication plan, to give phone calls and reminders, and to form that helpful, trusting relationship, to even move the logistics of her PCP relationship to somewhere that's much closer and more logistically feasible to get transportation services to, as well as to not overtax her stamina on a very long round trip to and from a doctor's office. The way I see those things are very human, very logistical. So even though the patient may be, quote, medically complicated, the solutions are not to be over-medicalized in nature. Again, being proactive, persistent, proactive in this case, as with the 64-year-old woman, was to say, hey, let's look at these meds and let's simplify. We will do that work of figuring out not only what medications can we simplify to go from 16 to 8, but how can we then also make the substitutions to make these medications more affordable, and how can we get you on a different plan to make the whole thing sustainable into the future. That's what we mean by proactive. We don't wait for the patient to ask, gee, doctor, can you streamline my medications? That rarely happens. So we need to look for those needs and be the ones to offer and come up with those solutions. One of the key tools that's emerging across the country is especially relevant for multi-visit patients, is an ED care planner, an ED care alert, as they call it in Maryland, which is kind of that brief synopsis of the multi-visit patient for that next provider who doesn't know her, so that he or she can get up to speed on the patient's pattern, the resources they have available to them, and what some recommended steps might be, or some information might be at the next point of care. Because a lot of our multi-visit patients kind of get automatically readmitted as soon as they hit our emergency rooms, because they look complicated, right? And so if we can again be proactive and help the next provider understand what's going on and what's in place. That has been proven to be very helpful as well. So a lot of great opportunity with our multi-visit patients. Oops. A companion to that is work in the emergency department to reduce readmissions in general, and this would be for any potential readmission. So one thing, again, that we've learned from our Virginia teams as well as from our neighbors in Maryland and elsewhere in bundled payments and accountable care organizations is sometimes the patient who's just been discharged does end up coming back to the emergency room. But that doesn't mean we have to readmit them. And so using the emergency room, if you will, as the last frontier of readmission reduction has proven to be a very effective element of a multifaceted portfolio of strategies. So a couple of the key concepts here are, if we see a patient, come into the emergency room who has just been here within 30 days, we can, ask some different questions, notify the care team. If they've been in a bridge program, we can reach out to the bridge folks. We could try to work in the emergency room to identify if the patient is truly acutely ill or if they just had a little bump in the road. And if we can safely and appropriately return them home or return them to the SNF with a warm handoff and a warm reconnection to the team that they've already been assigned to, we can, in that way, effectively reduce readmissions as well. And so we have some key points on that strategy. We covered two other special topics in the Home is the Hub series, and we were really excited to have some special guest speakers. And we had one dedicated webinar about working with payers, and it was happened to be Anthem Blue Cross, but I'll tell you, working with payers is an emerging element of successful strategies. We are increasingly seeking, to achieve the same goals in terms of long-term stabilization and avoidable cost and high quality. And so the triple aim is bringing payers and providers in closer alignment with each other. And a couple of things that we can do, especially with our more complicated or multi-visit patients in particular, is we can, case conference and understand what resources has or can the payer mobilize, what information does the payer have that we might not have at the point of care, and vice versa. The payer knows that we as the providers have information about either behavioral health issues or social needs that they can't readily see in the claims data, such that coming together more and more, especially around mobilizing services for the higher utilizing patients, can be very effective to work on over time. And then the final special topic that we covered was the emerging role, the evolving role of community health workers. And of course, we all know that a multidisciplinary team is very effective in primary care, in our hospital care, in our post-acute care, and adding community health workers to that multidisciplinary team is just proving time and time again to be a great value. Community health workers is a general term. We heard in the case example about the coordinators, the bridge coordinators from the Elder Service Agency. These types of community health worker, navigator, coordinator, advocate type roles are those trusting, helpful relationships, as Peter said, that goes beyond the specific nursing or medical or PT task at hand, and rather looks at the whole person, looks at the environment, looks at the home, tries to identify the struggles that are not being easily seen, and helps be the patient voice to bring problem solving and the multidisciplinary team approach to generate the solutions that the patient needs. So again, very helpful. And as you think about strategies to improve your hospital-wide readmissions, you might want to refer back to some of the resources and key points about community health workers and navigators and other such resources on a team. So moving here into a couple, the green section. This is the last section of the playbook. This is a section of if you do nothing else, please think about this type of a section. So we have a small handful of recommended actions. So recommended action number 1 is know your data and know your root causes. The most successful teams, they know their data, they slice it, they dice it, they track it, they trend it, they post it. If you have a high readmission rate, it's nothing to be ashamed of, because if you post it and commit to improving, then that is power. We don't want the readmission dashboard to only live in the executive suite. We want your frontline team on the floor to know about it. We want your, special programs like your bundles or your readmission reduction bridge program or whatever to know how are they doing. Data is motivating. Data brings insight to the frontline teams as well as to their managers and executives. The companion to knowing your data and tracking data is that data does not necessarily give insight about root causes of readmissions. And so, as you've heard us discuss over the years, really getting to the bedside, doing readmission interviews, getting a 360, if you will, perspective from patients and their family members or their providers or the SNF who sent them in or the dialysis center who sent them in or the PCP who advise them to call 911, whatever the case may be. We want to get a 360-degree view of what was going on that led the patient to come back to the hospital. Always asking ourselves, was there some signal along the way where we could have done something differently if we had more monitoring or a more responsive system in place for this patient? So data and root causes hand in hand, but we want to remember the root cause analysis is best done at the bedside in a conversation, not limited to data analysis alone. A few key elements are here on the slide. You want to know the groups of patients that have high readmission rates. So high readmission rates would be like your CHF population that has a 20-some% high readmission rate. You also want to balance that with knowing the patients who have a high volume of readmissions. Now, this is a great example of the post-acute care patients. Probably 20-30% of your patients are being discharged to post-acute care. They are high rate and high volume, which makes them high leverage. Another example is sepsis. Sepsis is the number one diagnosis that leads to the most readmissions, even though the readmission rate itself might be more like 16-17%. So it's not up in the 20s, but it's leading to the most readmissions. So these are some of the tips that we hope you don't just skim over, but you really kind of dwell on these specific tips. Say, what do they mean again by high readmission rate, high readmission volume? Do we know how many readmissions we have per month? Do we know how many readmissions we have in our target population per month, et cetera? So try to really drill down in the next couple years to that next level of granularity and command of your data. The next recommended action that can be very helpful is to articulate your strategy. We know everybody's working on a whole bunch of things, but it can be very helpful to pull it all together in a tool like a driver diagram that we've discussed before, or some other visual map of what are we doing for which patients. And then when you have that map visualized, ask yourself, how consistently are we delivering that service or that practice to each patient in that target population? Oftentimes, once you have a good strategy in place, as many of you know, the key to getting results is executing consistently, right? And so I'll bet that you'll have a lot of great success in the next upcoming year. If you feel like you have a good strategy in place, well, then focus on reliable execution on that strategy. Periodically review the strategy you have in place, because success begets greater experience and expertise. And as you get better at reducing readmissions, you will see the next 2, 3, 4 opportunities for improvement. And so, just because you started with, let's say, a heart failure program, you're going to then learn that your heart failure patients and your COPD patients and your, some other patients really kind of have anxiety, or they have these economic or transportation needs, or they should be enrolled in various community supports that you come to learn, and you will identify not only services for your current target population, but then by extension, you'll say, oh, we should do this for other patients as well. So periodically look for gaps, fill those gaps, because the great thing about this work is as you go on and have more success, you will actually identify more problems that need to be addressed, but that's a good thing. That means you're getting better. All right. So, a third recommended action, one that we have emphasized and I again really recommend, is to actively collaborate across the continuum. The natural place and the place where most Virginia hospitals are on collaborations with post-acute providers, skilled nursing facilities, home health agencies. That, again, that is the right place to start. It is an excellent place to start. Don't stay there. Don't stay there. By the time you get to 2020, you're going to want to grow and develop and foster an active cross-continuum collaboration relationship with your area agencies on aging and elder services and county services and behavioral health providers and the other social service agencies in your area, with payers, especially as payment policy and payment models change. As you collaborate, remember to take the receiver's perspective. I was just in New York yesterday with an emergency medicine doctor that was meeting with a bunch of behavioral health providers, and the first meeting didn't go well. It didn't go well because the behavioral health providers convened in the room. They were threatened by not understanding what was this emergency medicine doctor saying, and why does she think that she, can say how we're supposed to treat our vulnerable behavioral health patients. And it was actually, it didn't go very well. So we were strategizing yesterday. Why didn't that go well? And we talked about the fact that the emergency room and an emergency room doctor represents a certain power dynamic, and that what she might want to do next time is, go into the discussion and ask them what the needs are they see in their patient population, why they send their patients to the emergency room, and then invite, how can we work better together? And in that way, take the receiver's perspective that says, that recognizes that there might not be on day one a flourishing, trusting, collaborative relationship, and we really need to build that relationship over time. So again, it looks easy in a bullet point. We know it's not easy. We know it takes, the art of human relationships. And one key practice to remember is, if you want to collaborate with providers or agencies in the community, ask for their perspective and then invite their opinions as to how we can work together better. And from that, you will foster a trusting and collaborative relationship. Finally, recommended action is whatever you do based on your data, your root causes, your cross-continuum collaboration, and your strategy. Whatever your strategy is, measure what you implement. And this is the message I was getting to earlier about execution. I've been fortunate over the past couple years to have a similar experience as we heard from Peter, which is in year one we didn't get results, but we kept retooling, we kept measuring, we kept learning, and in year 2 and 3 and 4 you start to see that trend go down. And I know that this has happened in dozens and hundreds now of hospitals across the United States. And a key message from this playbook is have a dashboard, measure what you're doing, continually ask yourself, how can we change what we're doing in order to better serve the patient's needs? And that's a very different paradigm than, I'll say, an old school enrollment philosophy that says, well, I offered the patient transitional care or home health services or whatever the case may be, but she declined, so it's her fault. What I would say to that is, how can we change the way we describe it, the way and the timing and the manner in which we present it, the purpose, and the benefit to the patient. And there's a lot we can do in terms of scripting and engagement strategies, and engaging the family or whatever the case may be, so that we can deliver the service that we want to deliver and have patients more and more say yes instead of say no. So that's just one example of always asking ourselves, if we're not delivering the service with high reliability, how can we change what we're doing instead of just saying, well, it's the patients that say no to the service, because of course that doesn't help anyone. So that's the overview. We have a few tools here. This is the readmission interview tool. Again, the reminder that the best data analysis does not give us the root causes of readmissions. We would really recommend and encourage and beg and plead, really, that all of you coming out of this webinar, if you have not interviewed 10 readmitted patients, it doesn't matter if you're a doctor, a nurse, a case manager, a social worker, a community health worker, a data analyst, a manager, an administrator, or an executive. I believe that everybody should have a name and a face to 10 readmitted patients. That will give you and your team a shared body of understanding of the humans that we're trying to help, and it will really advance and strengthen the ideas that you have on how to help those people. And so here's a tool for that. Here's also a tool. Again, it's kind of a discussion guide, really, on building and fostering those hospital and, in this case, skilled nursing facility collaborations. There are questions you can ask of yourself. There are questions your skilled nursing facility can ask of themselves, and then there are discussion questions to identify shared areas of opportunity and come up with a few committed action steps to move forward. And so this type of a tool might just be very helpful if you are still in the process of going from networking and relationship development, and you want to move into some specific action steps together. So we would recommend you take a look at that. And then finally, these are the last 2 resource pages of the playbook, reminding you of the webinar series and the links to that, the data and the resources available through VHHA, as well as Health Quality Innovators, a series of videos and webinars. There's so much information that we know you can't necessarily digest it all, but this is where I would go for any given topic to take a deeper dive into. You're going to find what you need pretty much on these last 2 pages. And so with that, thank you for your commitment to reducing readmissions. It's been an absolute pleasure to work with the VHHA and HQI and other partners on presenting this body of information to you. And I'm just very hopeful that you'll find this playbook something that's practical and relevant and feasible, and just enough information to keep reminding you of some good ideas to forge your path ahead. So with that, I'll turn it over to Carla Thomas. Carla?
Well, good morning, everybody. It's so great to be on the call. Thank you, Abraham, for the opportunity. And I just wanted to share that HQI is so grateful and excited to be part of the supportive team for Home is the Hub initiative. And we are excited to support the strategies in the playbook. As many of you already know, we're supporting 10 community efforts across the state to reduce hospital readmissions. And whether you're working with us in one of the communities, or not, as your Medicare Quality Improvement Organization, we're really committed to statewide and local improvements with care transitions. 2018 is also a year of action for many of the care transitions communities supported by HQI. So we're really excited to align any strategies within the playbook to local opportunities. And it's really these local partnerships and tests of change that are creating some exciting momentum and improvements. We are really committed to spreading the learnings and successes from the communities to everyone statewide. I just wanted to mention a few ways that we're supporting your action. And there are much more than this list, but as Dr. Botwell mentioned, you have a lot of data, and data is really important to measure your improvements. We also provide your quarterly hospital Medicare readmissions data reports, and just this week we uploaded these to Quality Net Exchange. It is a secure portal that your members of your quality department should have access to. We know that you have various data reports, but we hope that these can really assist you with monitoring your progress with Medicare readmissions. Please don't hesitate to reach out to me if you need some assistance or have any questions about these reports. In order to support your many hospital interventions or strategies and any new ones that you may adopt in the playbook, I'd just like to mention to stay tuned for some additional data from us to help you determine how those efforts can impact your local community goals and contribute to the statewide 20% readmission goal that Abraham stated earlier. So we're working on some additional reports that might help you figure out what you need to accomplish specifically to help with the goals from a data perspective. A lot of our work supports and assists local collaborations, and many, as you might imagine, start with the local skilled nursing facilities, as they are some of the first receivers of patients and the most patients at times. Even more improvement activities have been initiated since Dr. Botwell was visiting Virginia in early December, where she conducted some regional meetings between nursing facilities and hospitals. And I'm excited to say that the one example of some of the increased collaboration has been around the concept of circle back. The circle back strategy is featured in the playbook and is really taking on a lot more momentum across the state. So Dr. Botwell first introduced this in the September 2016 webinar about post-acute strategies. And this started the day after that webinar in Richmond, where the RVA Care Transitions Coalition talked about what they learned on that webinar. And it took one hospital nurse navigator saying yes to trying circle back and measuring her success that really inspired others to try it too. So we interviewed Joyce Perkins here in our Ideas at Work video, and we since created a circle back implementation guide that is committed to helping people spread this idea more quickly based on the learnings and tips and successes that have been trialed with this intervention. So this is one way that we are committed to helping some of these interventions and strategies spread more quickly across the state so that we can make even more progress toward that goal together. This year we'll be featuring resources and stories about successful strategies for your readmission reductions in our monthly newsletter, Quality. So if you don't receive our monthly newsletter, please contact me. As always, don't hesitate to reach out to assistance so that we can help make those playbook strategies a reality to impact your local and statewide goals. That's all I had.
Great. Thank you very much, Carla. Thank you very much, Dr. Bout. Thank you very much, Dr. Boutwell, and thank you very much, Peter, Mr. Mulkey. So we do have some time now for questions and answers from the audience. So if you would like to ask a question of one of our presenters, I would recommend that you type your question or inquiry into the chat box and post your question to the organizer and panelists, and we will respond to them. So we'll give folks a few seconds to see if they have any questions that they would like to pose. So I'm looking at the chat box on my end, and I don't see any questions coming in. Teresa, do you see any questions on your end? Okay, well, I will go ahead and move through our closing remarks, and I will keep my eyes open in the event that we have questions posted to the chat box for our presenters. So as we move into 2018, the VHHA, we've identified sort of 4 areas of focus that we will be supporting throughout this year. The first is execution. As Dr. Boutwell referred to, we really want to encourage hospitals and their partners to use the playbook as a guide for implementing the appropriate high-leverage strategies that have been reviewed over the last year and a half through the Home is the Hub initiative. As Dr. Boutwell indicated, that it's very important that your efforts be data-driven. So understand your data, know which of these strategies would be most effective for your organization in reducing readmissions, and then execute. I can't overemphasize that enough, but our goal is not to introduce significantly new sets of content this year, but to really support you in your execution efforts. Secondly, the area of post-acute. A lot of content provided regarding post-acute transfers this past year. Dr. Boutwell was here in Virginia in December and facilitated a series of regional meetings around the state where hospitals and post-acute providers came together. What we identified during those conversations was a need to standardize some of the communication strategies being utilized by hospitals, and specifically our skilled nursing facility partners. And so we will continue that dialogue throughout this year to try to provide some assistance in standardizing the communication between hospitals and skilled nursing facilities. Another area is the area of sepsis. Dr. Boutwell indicated that when you look at national data as well as Virginia data, sepsis is often one of those diagnoses that is very high on the list when it comes to readmissions. HQI as well as VHHA, we have done some work around sepsis specifically, and we will make those resources available to hospitals and their partners. As you analyze your data and you see that sepsis is a high contributor, we want to make sure that you have the resources available to assist with that particular area if that is a high leverage strategy for your organization. And then finally, the area of disparities. CMS has made a number of resources available to assist hospitals identify key issues and strategies impacting readmissions for diverse populations. And especially in the area of the multi-visit patients, as organizations around the country have focused on that area, they've identified that certain populations are at higher risk of readmission rates, and that there's the strategies required to impact that may be different based upon some population-based demographics. And so we will be making resources available to hospitals to identify if those issues are relevant to them and what strategies can be used to impact those populations. So I'm looking in the chat box one final time. I don't see that we have any questions posted. I will check with our organizer, Teresa. Teresa, are you seeing anything on your end? You may need to unmute yourself, Teresa. Okay, hearing nothing from Teresa, we have no questions on her end. So we will actually go ahead and conclude this morning's webinar. We would like to thank you for your commitment to improving care across the Commonwealth of Virginia. And if you have any questions of us, feel free to reach out by email. The playbook is available on the website for download, so we encourage you to make use of that. And we look forward to working with you more throughout this year. Thanks again to our panelists, and you all have a good day.